We are here in the EAU Congress in Stockholm, and I would like to present to our Russian urologist, Professor Bogaert, who is very specialized in bedwetting, different types of everything that is connected to bedwetting in adults in pediatrics. And so, Professor Bogaert, what was new things regarding bedwetting presented here at the Congress? How do you think?
Actually, right here at the meeting, we specialized in summarizing what happened in 2013, what was published specifically for bedwetting. The first thing is that we always thought that it is very important when you start a treatment with desmopressin, for example, that you should actually limit it slowly by slowly, but apparently you can also stop after you have been taking desmopressin for a while. Another thing also is that the sleep in bedwetting is a very important factor. The quality of sleep of the child is compromised when he would lay in a wet bed. So it is very important either to keep the child dry, or, for example, that the child would wear a diaper. It is very strange because children don't like to wear the diapers, but it is very important that the child wears the diaper, because that way we know now that the sleep quality is improved and is as normal as a child who would not wet the bed. Also very new is that we know that there is also an association with sleep and probably also breathing during the night. Children who would snore, okay, have a higher chance to have also a problem of bedwetting. So if you have a child who wets the bed, you should always ask if the child also is snoring, and they should see an ear, nose, throat doctor to find out if that could be also one of the problems.
And what is your opinion about the recent reports about the impact of polyuria in adults? And as far as I understand that there's some tendency, for example, to pay attention more to polyuria in adults, the same as in children, and using the same medicine for the elderly. What do you think about it?
Well, I think you have to make some kind of distinguish between normal adults, I call it, or elderly people. Because I think when we are adult, we sort of should be able to have a good hormonal balance during the day and during the night. However, in the elderly people, you have a combination of other factors. For example, those people take diuretics sometimes or have other problems. Also, it's not to neglect, for example, but people drink differently, okay? People should drink in the morning and not so much in the evening, okay? But of course, also elderly people have problems with overactive bladder at night. So I think it's most of the time a combination of both with polyuria due to different factors where they can actually influence themselves or not, together with a start of nighttime overactive bladder. I think it's a very important issue, because if elderly people wake up at night and have to go to the bathroom, this is one of the most important problems where they can fall, and then other problems can occur. So I think it is nocturia is a very important issue for the health of the elderly people.
And do you think in future will we use desmopressin also in adults?
I think in certain indications it is quite good that you can use desmopressin. In elderly people, however, in contrast to children, in children we sort of all know that the renal function is normal, but in elderly people you should check electrolytes and indeed look at other morbidities before you just start with desmopressin, but it can improve indeed the quality of life.
And I would like to ask some like a private question. What about your personal opinion about monosymptomatic enuresis? Because as far as I feel that it's not so widespread as we can see. It seems to me that it's not so many people, children have monosymptomatic, really monosymptomatic. How do you think, what is the real rate for real non-symptomatic enuresis? Or those people who has monosymptomatic, they are not very well diagnosed, they're not diagnosed enough?
I think the incidence of bedwetting in children is quite well known. A lot of, how would I say, numbers and articles have been published that the incidence throughout the world is about similar. And as a rule of thumb, I think at the age of 6, there is about 15% of all those children who would still suffer from monosymptomatic bedwetting. At the age of 18, it is a little bit under 1%. So it's an exponential curve. Now, there is a difference between where parents would seek a doctor or not. So it's also about the awareness. Also last year we had quite a couple of articles that have been published about the awareness in parents and what they know, what they think, why the child would wet the bed. It was quite impressive to find out that parents think that the child is lazy, and that is one of the reasons. Also, another study has shown that quite a lot of parents are still punishing the children because they wet the bed. And we were thinking maybe why is that? And it was even shown that people with a good education, they would punish their children. So it's not because, you know, you would not have a higher diploma that you would know why your child would wet the bed indeed.
And so in this case, can you give some basic rules, for example, not even for pediatric urologists, they're quite known with this problem, but for example, for pediatricians, what they should start with and when they should ask for pediatric urologist to consult the patient?
Okay, I think it's a very good question, and I will try to answer very simple. I think the first thing is to make a good history, and to send the patients home with a voiding diary, I call it, but also drinking habits. When does the child drink? What and at what time? And then something very simple. You have to weight the diapers, because the weight of the diapers, 1 gram equals 1 milliliter. And you will immediately know if the child has a nighttime polyuria or if it's another problem. And by looking at the drinking chart and the weight of the diapers, I think you can actually make a start for the treatment. The second thing is, the most important, is to explain the child why he wets the bed. And it's very easy. It's only 3 factors that come into account. And the first one is always the children would sleep much deeper than others. It is not very scientifically correct because we say they have a high arousal. It's very difficult to wake them up. But the parents always tell them they sleep very deep, so this is why I tell them you sleep so deep. And then you have one of the both factors, either you have a nighttime polyuria or you have overactive bladder, okay, or you have both. And that's actually quite difficult to find out, but the nighttime polyuria you can find out just by weighting the diapers. So this is one of the first steps. And then you can explain, okay, either you do nothing and just keep the diaper on, like other children have to wear glasses to see, and well, you have to wear a diaper to sleep dry. The second is to adjust really the drinking habits and give at the same time medication, desmopressin, and I like personally to give also an anticholinergic for the possibility of overactive bladder. And the third one option is to teach or to learn the child to become less deep sleeper when he would void at night. And that is with the help of the wetting alarm. But then you need good parents and you need good guidance of the family. Personally, I think you should see these children every day, every week, how it goes, to help them, to teach them, to encourage them. Because if you tell them, here you have a wetting alarm and you come back to see me in 3 months, you will have no good success. So it's quite a lot of time investment for pediatricians or urologists. It doesn't matter, but I think that is the most important factor, and you will see you will have success.
And the last one question, what is the most modern concept on the how long you should wait for the result of the treatment you use?
I think for the treatment of drinking habits and medication, you should see it quite fast, within 1 or 2 weeks. Okay, the desmopressin you should build up and increase eventually the dose. However, for the wetting alarm, our personal experience is to have them about 8 weeks, so about 2 months, before we can really say now you are dry. So the wetting alarm takes a little more time and more effort, whereas the drinking habits and desmopressin, you have a quite fast result and success.
Okay, thank you very much. It was the latest news regarding bedwetting that we get here in the EU Congress. And Professor Bogaert, thank you once more for your interview, for your time.
You're welcome.
Thank you very much.
Bye.